So the relationship between the penal colony and the current state of affairs with regards to over-incarceration of Aboriginal and Torres Strait Islander peoples is certainly well documented across history, and in its contemporary form is linked to do with factors around poverty and disadvantage, over-policing, hyper-vigilance that is focused on this marginalised community, and the relationship with the justice system being hyper-militarised. And so there is transgenerational incarceration. There is certainly health plays into that in terms of disadvantage, disability, and the inability or lack of accessibility to things that keep us healthy and happy, such as stable employment, stable housing, etc. Oops. Statistics that are striking that my Australian colleagues may be aware, and it's not too dissimilar to perhaps the story of African American men or Latino people in the States, but 55% of all incarcerated children in Australia are Aboriginal and Torres Strait Islander. Approximately a third of all adults are Aboriginal and Torres Strait Islander in our custodial or correctional centres. So if you're an Aboriginal child, you have 20 times the rate of being incarcerated compared to a non-Indigenous child. And basically, despite a drop in crime rate and despite a tendency towards decarcerisation with COVID and removing people from close confines from one another, the rates of incarceration of First Nations people continue to rise. And so how does this all play into dermatology? There are really clear, simple examples to help explain why dermatology and the First Nations health gap are intimately linked. For example, the 60-fold increased rates of acute rheumatic fever and life-limiting rheumatic heart disease is intimately related to the epidemic of scabies and streptococcal skin infections. The rates of death from lupus nephritis, neuropsychiatric and hematological complications from systemic lupus erythematosus obviously has cutaneous manifestations, and that's a 9-fold increase rate. We have cancers of the skin, which are often neglected for a few reasons. 1, late presentation, 2, access blocks and dermatology deserts, and things like health behaviours such as smoking, predisposing to specific types of cancers of the oropharynx. Racialised systemic access blocks is, of course, part of that story, and that leads to ultimately a 10-year life gap. So my service that I take care of, this is the main prison service that I care for, that's approximately 800,000 square kilometres or 300,000 square miles. And there's about 40 centres there, 6 of which cover children from the ages of 10 through till 17. And we take care of about 30,000 patients per year. There's a huge number of people that are aging within jail, which means an increased rate of skin malignancies. There is other forms of marginalisation beyond First Nation status, and includes people who have limited literacy, English, head injuries, educational disadvantage, and a significant proportion of mental illness. In tropical Australia, I work at a children's detention facility, which is quite infamous, called Dondale, and became kind of part of the national discourse about how we care for young people. Again, 10 years through to 17 years, these kids are all grouped together. And in tropical North Australia, where you can see the red, that's kind of the part that this covers, this is how we would take care of a child that was suffering with perhaps behavioural disturbance, and was featured quite broadly in the media. There are some good features about people that work in places like this, but generally speaking, the care turnover is rapid, and people do the best that they can in the time they've got with the kids, but the kids are not well taken care of, and they come with a life of polymorbidity from the prenatal period, including fetal alcohol spectrum disorder and complex physical and mental health issues. So the average way of accessing care for people that live in jail is complicated and very hierarchical. There are many people who are incarcerated who know how to access the system swiftly, and people, you may know people like this in your public hospital systems where they know how to get an appointment quicker. And these people also do very well in jail, and there are some people that do very poorly in jail with accessing healthcare. Typically at reception, if you're erythrodermic with psoriasis, that will be identified visually, but not necessarily screened for or asked about. And so most of the ways that people come to medical attention is by help seeking. My problem that I already have is deteriorating and worsening, or I have a new problem, I have a new growth, I have a new lump, I'm worried. The next step will be that they self-initiate treatment. So, for example, cleaning products that are used to mop the floors by people that have special cleaning kind of designations and occupations will be distributed and shared amongst each other. Or if they're lucky, a nurse will be able to intervene and, usually offers them a bland moisturiser or an antifungal cream. At some stage, through enough complaining and enough requesting, you will end up with primary care, and those clinicians are excellent, but there's not enough of them. And then at some stage, if you're lucky enough and you circle around this loop of kind of trying to access help, you will end up with a dermatology referral, which may or may not land you an appointment. And if that appointment happens, if you're fortunate, you'll get a face-to-face appointment with me, but sometimes it will be telehealth based on the vast geography of the areas that we cover. And so at each step of the way, the number of people that are employed to address each of those issues becomes smaller, and the access barriers become more challenging, and it becomes more costly. This is how you access help. So you have to have a command of written English to be able to access help, because it needs to all be formalized based on, protocols and policies. And you can see, this person here has a rash and needs some help, but the ability to articulate your needs can be quite limited and very, very distressing if you can't express that well in written form. We use the DLQI all the time in dermatology, and it's so easy for somebody like me to go, yeah, I'm really itchy, or I can't wear my normal clothes. But in jail, you don't get a choice of what clothes you wear or what your occupational day-to-day kind of pursuits might look like. And also the issues around literacy, being able to process I suppose that agreeable, yes, let's tick the boxes, process this form effectively means that we really don't have a good understanding of how people's experience of living with a visible, othering, stigmatizing, and highly symptomatic set of diseases, how that feels for them. We often in dermatology, we would all be guilty of saying these phrases like, oh, come back if there's a problem, or we can do a biopsy of this today if we're not exactly sure what's going on, or, certainly in Australia, come here, let me freeze that off. I can kill that little precancerous spot off for you now. Avoid things that might make your skin angry. Those phrases are just irrelevant in a custodial correctional context where everything is irritating on the skin, where the water is a fixed temperature that's usually quite boiling. And where the kind of general skin health hardware is extremely toxic. And so all of us in dermatology know that we save lives in ways that may be less measurable to the intensivists or to the emergency physicians. But I think what I do is about restoring dignity and well-being. So these two stories I've got aren't actually about saving lives, but perhaps they have a role in recidivism prevention. And I'm going to play this for you. It may or may not work, and it doesn't matter if it doesn't.
Oh, well, look, I think the main thing that used to annoy me is when I was trying to seek treatment for it, it's that, you get all these people on that bube stuff and methadone and all that. They're seen straight away. They're given whatever they need straight away. But someone like me that was born with a condition that is hard to control outside, let alone inside jail, I had to jump through a million hoops to even see a doctor. And then a doctor's like, well, let's try this. And then when you go and see the doctor again, it's a different doctor. And then they say, okay, no, well, I don't agree with that. Let's try this, before they even recommend you to a dermatologist.
I'm not putting this up for you to read at all, but this man wrote me a letter when he left jail. So this man spent about 8 years in jail for serious offence. That's the kind of length of time that an Australian person would get for something that, you know, it was a long time in jail. But I've highlighted some things for you to look at. I've had a lot of struggles and complaints, and without treatment, I was bleeding. It was really debilitating. I've deliberately not edited his spelling. This is him speaking to you and to the justice health system. He knew he was uncomfortable, but other people were uncomfortable around him. Getting treatment, and that was through the form of a compassionate access biologic medication, helped a lot, and he feels like it's going to address his previous offending behaviour to move forward and be a benefit to society instead of a concern. He was not the only one suffering, and he was not being managed properly. And for somebody like that to take the time to write to me and explain his gratitude is quite a profound thing. We have gotten him better and have kept him better in the community, and he's now on government access biologic, just the way I would be if I were able to access it. And we may be able to celebrate that legislation may be changing about helping people access biologics in jail in the coming weeks, which is exciting. I've shown this to my Australian colleagues before. This lady's never going to die of her keloids, but she's also not going to get meaningful employment with these keloids in place. She lives 10 hours in a car from anywhere that is remotely accessible in Australia to get this kind of problem sorted. I didn't ask her to braid her hair and smile for the second picture. I didn't ask her to look washed out and fed up in the first picture. I said, let's just get some photo documentation of the before and after. You can appreciate there's a garrote mark, and I don't know if that's self-inflicted or inflicted on her by somebody else. But this woman got her problem fixed before she went home, and she was not able to get that problem fixed where she was going because there are no dermatologists or general surgeons where her home is. And I'm told that she's working and she's proud and she's got her kids back. So that's a nice story. So I suppose in summary, what I'm trying to say is applicable across any developed or any country where we have health gradient access issues. In Australia, I have the best access to the best healthcare, but there are people that don't have that. And the people that don't have that are the First Nations people, particularly people who are incarcerated. Chronic disease burden is high, and living in jail with a chronic disease that is untreatable or has legislation that prevents getting access to good and safe treatments is a really big issue, and the current system excludes incarcerated people from good healthcare. Basically, the goals of the United Nations through the Mandela Declaration on how we should be taking care of people is not being met in Australia. People living in incarceration face delayed diagnosis and an even greater delay to good quality specialist care. And this gradient is steeper for marginalised people. And getting people what they need with regards to, general health care, just the skin, we have all experienced being deprioritised, but a small generalist workforce really does have to figure out what's going to kill somebody today. And so me slotting in and taking some of that burden off them to see people promptly is helping people live healthier and happier lives. It's really important how we speak about people that live in jails. And I think as leaders across the dermatology world, we need to make sure that we talk about people with humanised language. They're not prisoners, they're not inmates. These people are people that are your patients, and it's up to us to lead by example. I also think it's up to us to lead by example with regards to diagnostic humility and fixation on the diagnosis that you want it to be in the treatment algorithm that might be cheapest and most easiest and agreeable in a specific environment is certainly something that we could do better with in Australian jails. And so the way that I have been able to achieve this is finding support from like-minded colleagues around the world. And that's been very motivating for me to know that other people care about this kind of work. The way that we're doing some of this work in Australia is by growing a workforce of people that have a connection to this kind of work already. And so we have gone from 0 fellows who have First Nations background to 4 in the space of roughly 10 years, give or take. And we're working actively, not in a way that is trying to be inflammatory around the current issues with affirmative action in this place, but in Australia, we're working very deliberately to recruit and retain and make welcome people who come from diverse backgrounds into the space of dermatology. And I'm very, very, very proud to be a part of that story and very fortunate to be an experiencer of the privilege that's been extended to me by mentors that have kindly looked after me. And that's all I have to say. Thank you so much.